Diabetic ketoacidosis, or DKA, is one of the most common and most dangerous endocrine emergencies you'll face in clinical practice. It carries a mortality rate of up to 5%, even with treatment, and mismanagement can be fatal. This video walks through the pathophysiology, the diagnostic criteria, and the evidence-based treatment protocol, step by step, the way you need to know it for both clinical practice and board exams. DKA occurs almost exclusively in type 1 diabetes, though it can occur in type 2 during severe physiologic stress. The fundamental problem is absolute or relative insulin deficiency. Without insulin, glucose cannot enter cells. Cells starve despite high blood glucose. In response, the body activates counter-regulatory hormones, glucagon, cortisol, epinephrine, growth hormone, which accelerate gluconeogenesis and glycogenolysis, making hyperglycemia worse. More critically, the liver shifts to fat catabolism. Free fatty acids are released from adipose tissue and delivered to the liver, where they are converted to ketone bodies, acetoacetate, beta-hydroxybutyrate, and acetone. These ketones are acidic. As they accumulate, they overwhelm the body's buffering capacity, causing a high anion gap metabolic acidosis. The three diagnostic criteria for DKA: blood glucose greater than 250 milligrams per deciliter, pH less than 7.3 or bicarbonate less than 18, and positive serum or urine ketones. All three must be present. The anion gap is elevated, typically greater than 12. Calculated: sodium minus chloride minus bicarbonate. In severe DKA, the anion gap can exceed 30. Common precipitants follow the 6 I's: infection, the most common trigger, especially pneumonia and UTI; insulin noncompliance, missed doses; ischemia, MI or stroke; intoxication; infarction of the bowel; and new-onset, previously undiagnosed diabetes. The I is a stretch, but the concept holds. Presentation: polydipsia, polyuria, nausea, vomiting, abdominal pain, and Kussmaul respirations, deep, labored breathing as the body blows off CO2 to compensate for metabolic acidosis, and fruity breath from exhaled acetone. Altered mental status in severe cases. On labs, elevated glucose, low pH, low bicarb, elevated anion gap, elevated BUN and creatinine from dehydration. Potassium is often normal or high on presentation, despite total body potassium depletion. Acidosis drives potassium out of cells. This is critically important. Once you start insulin and correct acidosis, potassium shifts back into cells and can drop precipitously. If potassium is below 3.5 before starting insulin, hold insulin and replace potassium first. Otherwise, you risk fatal hypokalemia and cardiac arrhythmia.
The treatment of DKA follows a clear protocol: fluids first, then insulin, then electrolyte replacement, in that order. Step 1. Aggressive IV fluid resuscitation. Start with normal saline, 0.9% NaCl, at 1 liter per hour for the first 1 to 2 hours. DKA patients are typically 3 to 6 liters volume depleted. After initial resuscitation, switch to 0.45% NaCl at 250 to 500 milliliters per hour, or normal saline depending on the corrected sodium. The goal is to restore perfusion and begin clearing ketones. Fluids alone will start to lower glucose. Step 2. Insulin. Use regular insulin, an IV bolus of 0.1 units per kilogram, followed by a continuous infusion at 0.1 units per kilogram per hour. Again, do not start insulin if potassium is below 3.5. Once glucose drops to 200 milligrams per deciliter, add dextrose to the IV fluids, typically D5W, alongside the saline, and reduce the insulin infusion to 0.05 units per kilogram per hour. The goal is not to normalize glucose rapidly. It is to close the anion gap and clear ketones. Continue insulin until the anion gap closes, pH is above 7.3, and bicarb is above 18. Step 3. Potassium replacement. Even if initial potassium appears normal, it will fall as insulin drives it intracellularly. Target potassium between 4.0 and 5.0 milliequivalents per liter throughout treatment. Replace aggressively, typically 20 to 40 milliequivalents per hour IV, when levels are low. Phosphate replacement is controversial. Replace only if below 1.0 with symptoms. Bicarbonate is not routinely recommended unless pH is below 6.9 and the patient is hemodynamically compromised. It can paradoxically worsen CNS acidosis and precipitate hypokalemia. Monitor glucose every hour and a basic metabolic panel every 2 to 4 hours. Calculate the corrected sodium. For every 100 milligrams per deciliter rise in glucose above 100, add 1.6 to 2.4 milliequivalents per liter to the measured sodium. Resolution criteria: glucose below 200, anion gap closed, bicarb above 18, pH above 7.3. Once resolved and the patient can eat, overlap subcutaneous insulin with IV insulin for 2 hours before stopping the drip to prevent rebound ketosis. DKA is manageable, but it punishes inattention. Know the protocol, monitor closely, and never forget to check and replicate potassium before starting insulin. Subscribe to Medical Sciences Unfolded for daily videos on clinical medicine, pharmacology, and the science behind the diseases you treat every day.